Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we'll learn about eosinophilic esophagitis treatment adherence from Dr. Mark Holbreich. Dr. Holbreich is a pediatric allergist practicing in Indianapolis. His research interests include the effect of Amish lifestyle and allergy protection, EOE, and the early introduction of peanut. Welcome, Dr. Holbreich.
Thank you. Well, thanks for joining us today. I am trained as a pediatric allergist, but in allergy, we see adults and children. And actually, my interest in EOE is primarily in adults. So today, the data I'm presenting and a lot of the information will be most appropriate for adults, teenagers too, and some of you who may have children with EOE. You'll be able. We'll make a few references to what we see in children. Part of the session today, or a large part of it, is going to be your feedback about your personal experiences with adherence. It's a particular interest to me, and I'm going to show you some studies about it. But I would hope that you would share some of the things that come up in the discussion today with us and other participants. I have my email address here, and if at some time after the meeting, or if you're watching this virtually, then you can contact me with some of your concerns about adherence. Again, as Jennifer said, I can't answer medical questions, but we're beginning a large research project, and your input will help us design the study. Can I have the next slide, Jennifer? So here's what we're going to do today. We're going to characterize EOE, which I'm sure you're familiar with. We'll review the adherence studies that are available. They're not a ton. We're going to talk about adaptive behaviors, which is a particular interest of mine. And then we're going to leave lots of time in the end for you to share with us and the other participants your struggles or your thoughts and where we can learn more about adherence. So the next slide, please. So I'm sure you're all familiar with this. This is the definition of eosinophilic esophagitis, and it is a disease that is characterized by inflammation of the esophagus and manifests most commonly by difficulty swallowing or dysphagia. So the majority of the patients that I see as young adults, teenagers, they present to me after having had a few choking episodes or more difficulty swallowing, and eventually an endoscopy and the diagnosis of EOE. But it is a chronic disease, and the best that we can say is that without some sort of intervention, the disease persists and gets worse with time, particularly without any intervention. So if we see a child who's 6 or 8 years of age, although there may be a period in their life where there is some remission of the disease, we don't feel at this point that it is gone completely. My personal feeling is that children in their preteen and teenage years find a way to compensate for their EOE and don't complain too much about it. But as teenagers and adults, it seems to resurface, although we need more data on this as well. Adults, once the disease is diagnosed, and adolescents, it tends to be a lifelong disease. So just like diabetes, hypertension, it requires ongoing care. Can I have the next slide? So we're going to talk about 3 studies today in eosinophilic esophagitis related to adherence. Now, for the purpose of the talk today, adherence is 2 things. It is the following of a plan by your primary care provider or your allergist or your gastroenterologist in how you manage your EOE, whether it's diet, medications, a biologic, dilations, and that's the adherence to the medical side of it. But also adherence involves routine follow-up. So the twice a year or once a year or even more frequent follow-up visits to manage your eosinophilic esophagitis is also a part of the adherence package. So it's both following up with physician recommendations and for care, and also following up with appointments. Now, this is a study done by Joy Chang, who's been very active in APFED in her work, and her particular interest is the issue of adherence. So this is a retrospective study, meaning that they looked backwards. So they looked at records from the University of Michigan in the emergency room for 17 years and identified patients who came in for a food impaction. So they identified 220 patients with a food impaction. These were not all EOE patients because you can have food impactions for other reasons. But they thought that between the biopsies that were done, because not every patient had a biopsy, and the history that they gleaned from the chart, about 50% had EOE. And of those 220, 55% never came back. Now, for those of you who have EOE and have had an impaction, it is one of the most uncomfortable things that people can go through. And most patients who have had an impaction really want to avoid having it again. So if you have 2 or 3 impactions, there's something going on that's not being taken care of. So you'd say, well, I mean, it's surprising that over half the patients never came back, but I think we see this in many chronic diseases, that there's a loss to follow-up. In the next slide. Now, this is a study from Holland done by a group of researchers at an EOE center. And this is a cross-sectional study, which means that when the patients came back to clinic, they had the opportunity to provide them with a variety of questionnaires and quality of life questionnaires that they filled out. And in this analysis of adults, 59% reported poor adherence. So again, we're in the, between 50 and 60% of patients with this chronic disease do not adhere accurately, effectively. And this is with medical and dietary treatments, because these are people who came back. They didn't capture people who did not come back. So again, a problem with adherence. Okay, the next slide, please. Now, this is a study that I did with Evan Dellin. Some of you may know Dr. Dellin. He's a very well-respected gastroenterologist in North Carolina who makes a study of what we call the epidemiology of EOE. Who gets it? How long does it last? Is it chronic? Is it not chronic? Is it male, female? Is it Caucasian, or is it other races? And so he's very well respected and helped me a lot on this study. So as I was approaching the end of my career, which is approaching quickly, I decided that because I had seen so many patients with EOE, about 100 new adult patients a year, that I wanted to get an idea of what was going on with them. So we looked through our patient database, and we identified 410 patients who were diagnosed by biopsy for having eosinophilic esophagitis, and that's between 2016 and 2021. And we got 100 back in the mail, and we defined adherence in this study as follow-up care. Okay, the next slide, please. So this slide, I just want to point out to you the population that we're dealing with, because I think it's interesting. I think it reflects pretty much what other studies have shown. So if we look at the age was 45, the average age, and it ranged from 16 to 76. We had a cutoff at age 16 for this. If you look at male, female, usually it's about a 70-30 or 75-25 for male, female in most studies, although we know that females fill out more questionnaires than males. So that's probably why there's a little bit larger percentage of females. Now, in my practice, which is in Indianapolis, in a suburban area, 100% of the participants were Caucasian. Now, that can be very different geographically. A colleague of mine is in Miami, and many of his patients are Hispanic. So it is a little bit geographic, but in Indiana, it was 100% Caucasian. This is another thing that I've observed, and I think others have observed as well. I know Dr. Dellin has. And that is, if you look at these 100 patients, about 82% graduated from college or had a graduate degree. And my experience is that, for reasons that are not clear to me, that many of the patients with eosinophilic esophagitis are Caucasian, well-educated adult males. So it's an observation, and I think it's been held up. These are just the presence of allergic allergic comorbidities, asthma and allergic rhinitis. And this is what we'll talk about next is compensatory eating behavior. So we asked them a series of questions about how they eat, and 89% reported that they had some modification of their eating because of their EOE. There was a significant amount of anxiety around eating, which is not unusual. Now, in terms of therapy, I didn't put the therapy in here, but the therapy was very variable from people who were taking a single medication, multiple medications and diets, all sorts of things. So Jennifer's going to put up the first audience participation question related to your experience with medication. So after your diagnosis of EOE and medical therapy was established, which is best described how you currently manage your EOE, would you say that you use an acid blocker and or a swallowed steroid? You're on an elimination diet, you're on dupilumab or a biologic. It's a combination of therapies, or currently you're not taking medications or diet regularly. In other words, you manage without regular therapy.
Okay, we're going to go ahead and close the poll.
Yeah, so it's interesting that in my questionnaire, 12% of the patients were not taking any medications, and during that 13%. Dupilumab is relatively recent, and 9% is a small percentage of people on it, but for those who struggle, it's certainly a new addition. And then a combination of therapies is common. So kind of across the board, but interestingly, there's a 13% who manage, and I think that's the group that I'm talking to in these next couple of slides after we finish the information of this study, because what is management? So can I have the next slide? Okay, so this is the result of our adherence study. And in this first column, you see those people who completed the questionnaire, and that was 100. And of those 100, 56 of them, or 56%, were seen within 1 year. So almost everybody came back. And those who didn't come back within 1 year, the majority were seen within the following year or two. 9% of the patients never returned. Now, that's a small, it's only 9 patients. It certainly could be a change of insurance. Maybe they didn't like what I had to say. Maybe they wanted their gastroenterologist to manage it. Or maybe they just felt they didn't need to come back. So not that many. When we looked at the other patients who did not complete the question, there were 238 patients, and we were able to look at their appointment histories. And we saw that those patients, only 9 came back within the first year, so not very many. Now, 111 or 47% came back within after a year, but still leaves 50% who never returned. So of the 238 patients I saw, 118 patients saw me once and never returned. And that's concerning. But when you look at Dr. Chang's study of patients who had a food impaction, 55% did not come back. And when you look at the Dutch study, 60% had poor adherence to medications. So this trend seems to be ongoing, and it's something that we want to explore, and that's why information from you about your personal experiences with adherence is important. So I think it's time for the next question. Or do we have another slide first? Okay, no, we have another slide first. Okay, so now remember on the study that I just presented, we talked about compensatory eating behaviors. And there is a designation called impact that's to help physicians ask questions about the patients. Now, I do a lot of teaching to other physicians and other allergists about treating eosinophilic esophagitis. And these kinds of questions are often not asked. So when you say to a patient with eosinophilic esophagitis, do you have trouble swallowing? The answer is occasionally or not very often, or I manage. It's not really a big problem. But then when you ask them specifically for eyes imbibing liquids, so do they drink water with every meal? And the question I like to ask them, if you go to a restaurant and your food comes, but there's no water at the table, will you start eating or will you wait for water? And very often people will say, no, I wouldn't begin eating. Modifying foods is cutting them into small pieces and using things like ketchup or sauces to help them go down. A prolonged eating is the person with EOE is often the last to finish. And a question I like to ask in adolescents, because my experience has been that I start seeing children at 6 months of age, not uncommonly, when they have their first food allergic reaction or they have atopic dermatitis. And I've been fortunate to be in the same place for 35 years. So a number of my patients now are in their 20s and 30s. And it is not uncommon when these kids are in high school and I see them back for their annual visit because they need injected epinephrine prescriptions for their food allergies or they have some mild asthma. I say to them, do you have any trouble swallowing? And they say, occasionally, a piece of chicken goes down a little bit, but it's not really a big deal. And then if I ask the parents, is your child the last one to finish eating? They say, oh, yeah. He's a really slow eater. She's a really slow eater. And they seem to chew forever. So that is, these questions are very important. Not eating certain foods like meats, breads, and rice that go down in a glob. Those are the ones that often patients avoid. C is for chewing excessively, which goes along with, being a slow to eat. And then turning away from pills. So many of my patients, when I ask them, how do they take their medications? They would say, I don't take vitamins or large pills, and I chew small pills, or I even chew my vitamins. And we don't know what chewing does actually to the effectiveness of medications, but many patients have what we call pill dysphagia, which is difficulty swallowing pills. So what we want to focus our research on and what I'm looking to you to share with us is how are you impacted by these eating behaviors? And we'll start with the next question concerning this. So this question number 2, prior to the diagnosis of eosinophilic esophagitis, did you always have water available to drink? Cut food in small pieces, avoiding meats and eating slowly, avoiding swallowing large pills, none of the above or all of the above.
Okay, we're going to close the poll.
Okay, all of the above. Okay, so the majority were all of the above. Let's go on to question number 3, Jennifer, and see. Okay, after the diagnosis of EOE and establishment of a therapeutic routine that you and your physician accepted as adequate, did you always have water available to drink? Do you always have water available to drink? Cut your food in small pieces. Avoid swallowing large pills. None of the above or all of the above.
go ahead and close this poll. There's the results.
So now I think this is interesting, of course, because still after establishing a third of the patients, a third of the participants, we're still having some issues with their eating behaviors. Prior to it, if I recall correctly, it was about 50%. So there's not been a huge drop, and still a number of individuals still have these eating behaviors. And then and if we look at none of the above, only 15% of you said that you eat without any problem. So now, do we consider this good care? Now, I'll tell you a little story. I have a colleague of mine who's a gastroenterologist in Switzerland who's very, very well known, very well respected, named Alex Drumm. And we've had a wonderful relationship over the past 10 or 15 years, sharing our ideas about EOE and publishing a number of papers together. And Alex said to me, he says to patients, do you have a dog? And if they have a dog, he says, yes, I'll be happy when you can eat like your dog. Now, if any of you have dogs, you know that you give them a piece of steak and one gulp, it's gone. So that's his criteria for good control, which would be called deep remission, where you do not have any problems. But here we have, only 15% who say that they have no problems after treatment, which leaves, 85% of you who are still struggling in some way. Now, part of that is this anxiety? Is this related to years and years and years of accommodating? Because we know that patients who present with a food impaction, or when I see patients who are in their 20s, who have had increasing dysphagia to the point where they've either had an impaction or go to see a doctor, when I take the history, I'll say, when is the first time you had any choking episodes? And they say, oh, I kind of remember in college, I was a freshman in college and I was eating a pork chop and it got stuck and I threw it up and I just thought I was eating too quickly. And then, 2 or 3 more times in college, I had little problems and then it's gradually gotten worse. But, I got by for many years. And how'd you get by? Well, I would cut my food in small pieces and chew it carefully and drink water and I get by. And that's what a lot of people say, I get by. Now that for on us, our side as the provider, we would like patients to say, yeah, I can eat like my dog. I can take a bite of steak and just swallow with no problem. But we don't do swallowing studies particularly. There was one study that was done by a group at Mayo Clinic where they actually observed patients eating and they measured how many times they chewed a piece of food and how many sips of water they took. And they took people without EOE, people with active EOE, and people whose EOE was quote unquote under management. And obviously the people with poor control had, many adaptive behaviors. The people without EOE had no adaptive behaviors. And those who were considered under control still had a number of these behaviors, chewing a lot, drinking water. So I think that we, as providers of patients with EOE, underestimate how much goes on with modifying eating behaviors. Because if you asked any, if you said to your provider, when will you be happy with my control? They'll say, well, when you eat normally, when you eat like everybody else. And that obviously in this group today, there are only 15 of you who seem to be, or 4 of you who say that you don't have any problems. So can we close this then and go on to the next slide? So I hope you've been sending in some things for Jennifer because, I spent about 25 minutes so far, and we have another, 30 minutes or so. And I want to hear from you about how we can do a better job of understanding our patients with EOE. So what keeps patients from coming back, or what would keep you, or do any of you have problems with accessibility? Can you not get appointments with your allergist or your gastroenterologist? Is it the cost of an endoscopy? I know many of my patients, if I say to them, well, you're probably due for another endoscopy. And they'll say, I'm still paying off the last endoscopy. So the cost can be appreciable. What are the reasons why people don't come back or come back for 2 appointments? And what's acceptable for your quality of life? Is adaptive eating as common as we think? Well, from the poll, I would say that it is very common because 85% of you still use adaptive eating behaviors. Now, are those ingrained in your brain and you just can't get yourself to swallow a larger piece of food or eat something a little bit tough or not have water with you? That's something we need to figure out. And what are the concerns about medications diet? Because 12% of you said, I'm currently managing, meaning no medications, no diet, no biologics. But we know this is a chronic disease. We know that high likelihood is if you had an endoscopy, it would be abnormal. So, um, what, you know, what are your concerns about adherence? And I'll finish up with one story about a patient who's not a patient of mine, but is the son of a friend of mine who over the years has said to me, I wish you could talk to my son. He has problems with EOE. And and finally I saw his father at a meeting just a couple weeks ago. And I think this young man is probably in his mid-30s. And so I called him. I said, how are you doing? He said, well, I'm getting by. I said, well, what is eating like for you? He said, oh, I eat a lot of soft foods. I drink a lot of water. I use a lot of sauces. I feel food going down frequently, but I manage. I said, well, when's the last time you were on swallowed steroids? He said, oh, I think my doctor gave them to me when he diagnosed me 10 years ago, but I never stuck with it. And I said, well, how do you manage for these last 10 years? He said, I manage. He said, my life is not great, but I have 2 kids and a wife and a job. And I said, you need to do something. So here's someone for 10 years has lived with a fairly significant narrowing of his esophagus, who has chosen to get by because it was too busy to do other things. But hopefully I have convinced him to start some treatment. So I'm anxious to hear what sort of things you've sent into Jennifer. And if you have any other questions outside of adherence, general questions about EOE, certainly those we can certainly address.
Well, thank you so much for sharing information about the research about adherence. So yes, we'll go ahead and open things up for questions and comments. Go ahead and open up the Q&A box if you're joining us today, and you can go ahead and submit comments there or submit questions, and we'll start our discussion portion. So, alrighty. So our first comment/question is about how to deal with adaptive mealtime behaviors. So this family has struggled with getting help to those adaptive mealtime behaviors, and they're looking for advice on who they can get help from.
Now, I assume this would be a child.
It did not indicate,
Yeah.
but they said they saw a behavioral health doctor recently in Ohio, but they live in Florida. So when someone is experiencing adaptive mealtime behaviors, what advice do you have?
I think in children it's sort of a different because I think they start these adaptive behaviors very early. So one of the things that parents say to me commonly is they pocket foods. They keep the food in their cheek and they don't swallow it and they gradually just sort of chew it up, or they avoid certain foods altogether. I think that is a problem. And I think the anxiety around eating is something that is very real. And I've had patients who have told me, adults, that they are eating only liquid foods, soups and things like that. And I'll say, you need an endoscopy. Then the endoscopy is normal. And then we do something called a pill esophagram, where they swallow a capsule the size of a pill. It goes down the esophagus, and the radiologist can see the transit of the pill. And one of my patients was perfectly normal, but he still would only eat soup. I mean, he lived on soup because he had so much anxiety around it. Now, of course, not knowing this family and the age of the person, I would say that what we see in general with allergies whether it's a food allergy, particularly with food allergies in children, that if the child has anxiety around eating, and if the parents have anxiety around eating, then the anxiety takes on its own sort of life. And even though the endoscopy may be normal, then the child may still have these eating behaviors because of some fears or anxiety. So if the scope is normal and the caliber of the esophagus is normal, when the gastroenterologist looks at the esophagus and says, yeah, it looks good, then you say, okay, there's probably some underlying anxiety, which, you know, most all of our patients, 50% of patients have anxiety about food eating. So in a child, I think you're saying, well, how do we deal with this anxiety? And I would say that a psychologist or a psychiatrist who deals with anxiety in general, because my suspicion is, and certainly I don't want to characterize any family as having something they don't have, but typically we tend to see it with children. I'll say to a parent, do you have anxiety? Does your child have anxiety in other situations? Say, oh yeah, when they have to do this or that, they get very anxious. And then may ask the parents, do you deal with anxiety yourself? And and anxiety is a genetic disorder, so there are familial traits. So there are eating programs and there are eating behavioralists that are in inpatient centers, the large pediatric centers like Children's Hospital of Philadelphia, and at Denver Children's Hospital, National Jewish Hospital in Denver. They all have eating programs for children. But I think locally you would need to address it with, why is my child anxious about eating?
Thank you for that feedback. So another topic that's coming up is accessibility. So if you don't live in a major urban area, the wait list to get in can be close to a year. What do you recommend for people dealing with accessibility issues?
That's certainly an issue. I mean, so people would come to see me after the diagnosis of eosinophilic esophagitis most often. So they were in the emergency room or they were having dysphagia and they were waiting. Now, accessibility here in Indianapolis is not that great. However, if you have an allergist who's taking care of you or your child, and there's a suspicion of eosinophilic esophagitis, or even your primary care provider, um, I always found, and this is certainly shouldn't be the case, but if I called personally and talked to the physician personally, the gastroenterologist said, I have someone here who's really struggling. Can you get them in for a scope? I mean, the scope takes 5 minutes, and it's usually not the doctor who's making the long waiting list. It's the people who answer the phone. And the doctor says, but if you say to them, listen, they'll say, oh yeah, I can do it over my lunch hour. And so I think you need to advocate for yourself or your child, and push your primary care provider or your other specialist to, make a call. And it's unfortunately what I had to do a lot, but you do it.
Other comments are coming up about the cost of treatments, such as the endoscopy. You shared a story about that earlier.
Mhm.
So, out of pocket cost for endoscopy is a factor in some households. One family member shared that they had an impaction that was treated in the ER. They referred to GI, but they never followed up because they figured it wasn't necessary because the impaction was removed. What kind of advice do you have for people about why they should or shouldn't follow up following an impaction?
So tell me the question why they should follow up.
What is the importance of follow up after a food impaction?
So when you have a food impaction, your esophagus has narrowed to the point where the food can't go down. And the causes of it can be a variety of things, but the most common reason that an adult shows up in the emergency room with a food impaction is EOE today. There are other causes. There can be acid reflux, which causes something called, reflux narrowing. There can be a tumor where, the food just gets blocked, but that would be with every single bite. So if you have a food impaction, the diagnosis of EOE needs to be excluded. So that provider, the gastroenterologist, would say you need an endoscopy. Now, the endoscopy involves an examination of the esophagus, and there's something called the EREF score, which describes the esophagus and its appearance. And there's the biopsy. And the biopsy is read by a pathologist and gives the report to the gastroenterologist. So, I mean, it is would be highly unusual for someone to say, well, the impaction is over, so you don't need a scope. I mean, it's that I've never heard that story. Now, I've heard the story that some people go and have a dilation, they get their esophagus stretched, and then I say, well, what did the biopsy show? And they say, well, the doctor didn't do any biopsies because he just stretched the esophagus. But you need to insist on having biopsies if you're going back. Now, the cost of the endoscopy is an interesting topic, and I've had to deal with it, seeing so many patients with EOE. So here's my approach. If you look at the literature will say, it used to say a routine screening endoscopy every year. Now, sometimes say every 2 years. And some of the gastroenterologists who are leading the thought process in the field may say, well, patient's doing well, maybe every 3 years. And so what's the purpose of the endoscopy? The initial endoscopy is to make a diagnosis. So the presence of what are called rings and furrows and these scores that are elevated, and to do a biopsy to look for the number of eosinophils. So if you have a good pathologist and can read it well, and a good gastroenterologist, the diagnosis is made very easily. Now, what's the purpose of follow-up endoscopy? Well, there are two components to follow-up. One is, how's my dysphagia? Am I doing better? And how's my scope look? So when I would put a patient on, and there's something I want to take a little slide for, and that's shared decision making. Shared decision making is what we now discuss, in that when I would sit down with a patient, when I see their biopsy, I see their scope report, I look at any allergy testing that I want to do, and I present to them EOE. EOE, as I understand it, chronic progressive disease that needs some sort of therapy. And then we go over all the options. Is it diet? Is it acid blockers? Is it swallowed steroids? Is it a biologic? And come to some decision together for whatever that patient is comfortable with. If someone says to me, I'm a little afraid of swallowed steroids, I'd like to try acid blockers, I'll try acid blockers. Now, I typically see them back in 4 to 6 weeks, 8 weeks after I initiate some therapy. If the patient says to me, I'm doing significantly better, I'm not having much problems, I'll say, well, let me see you back in 6 months. They come back in 6 months, I'm regular with the medicine, and I've not had any problem swallowing. And say they're on a swallowed steroid and they're on a good dose of the swallowed steroid and they're conscientious about it, they're adhering with it. I say to the patient, what are we going to gain from a scope? Last time you had 100 eosinophils in your biopsy and all this inflammation, you're feeling much better. If we do the endoscopy and you have 32 eosinophils when you want to have less than 15, are we going to change anything? Are we going to give you double the dose of steroids? Then you're already on the maximum dose. So I give them the option. I say, listen, if you're feeling fine, you're not having problems, I don't feel the need to do an endoscopy because I don't do it. I'm not saying that the gastroenterologists do it because it's a source of income from them, but that specialty sort of says, this is what I do. You come to me for a checkup on your EOE. I'm not going to say to you, well, you sound pretty good, you don't need a scope. They're going to say, yeah, it's been 2 years, you're due for a scope. But I've had patients that I followed for 10 years who've only had one endoscopy because they're conscientious with medications and they are symptom free. Now, on the reverse side of it, if someone I'm treating and I'm working hard with them and we've done a few different things and they're saying, I'm just not feeling better, then I'm concerned there may be something called a stricture. A stricture is a very narrow area of the esophagus with scarring that needs to be opened up with a dilation. So sometimes I'll say, listen, we've been working on this for a couple of months. I'm not happy where you are. I really need you to have an endoscopy. But if someone says to me, it's February, my deductible's $10,000. I know this is going to be $6,000 for me and a day out of work. I say, well, then don't do it. What am I going to learn from it? What's it going to do to change the outcome of your disease? So I think if you're doing well, you can argue that a scope is not going to be valuable. I think if you're struggling, then you say, yeah, I probably need to do it. But the cost is an issue. Now, there are some things that look promising. In Denver Children's Hospital, they are now doing transnasal endoscopy, where they put a scope through the nose and into the esophagus and do the biopsies with no general anesthesia. The procedure takes about 10 minutes, and the biopsy results are good. There's another thing called the string test, which is a capsule you can swallow that deploys a string into your esophagus. It sits there for 30 minutes. The string is taken out. I think there was a webinar about it a few weeks ago. That's still a little bit difficult because only the lab in Denver analyzes the string. It has to go to the hospital from your center to the other on dry ice, which would make it difficult for me to do a string test in my office because I'd have to go out and buy dry ice and then ship it. And insurance doesn't cover all the costs. But I do think as time goes by, there will be less invasive procedures. The goal has always been to look at what's called a biomarker, something in the blood. Can we look at something in the blood, eosinophils in the blood, or some marker that has never panned out to be adequate? But I think that the shared decision making is really the catchword now. And if you're sitting down and your doctor says, "Well, it's been 2 years since you had a scope, you're due," and you say, "Well, what are you going to change? I'm doing fine. I'm not having any problems. What's it going to change?" I'm going to say, "Well, probably nothing." So you say, "Well, I choose that I don't want to do it." So long answers, but good questions.
We've got lots of good questions coming in and comments as well. So
Okay.
another comment that came in talked about the challenge of having a good treatment plan following diagnosis. So this particular individual said they didn't feel like they had a good treatment plan. There wasn't a follow-up allergy test. There wasn't a referral to other specialists to help. What types of specialists do you recommend someone with EOE work with in addition to their allergist or gastroenterologist?
Well, you need either an allergist or gastroenterologist to help you because no one else is really expert in this. Now, APFED does have a list of regional specialists. So you can go to the APFED website and you can look for your city. You can find either a gastroenterologist and allergist who is shown an interest in eosinophilic esophagitis and who you can discuss with. I think, when you now the Academy of Allergy, which is the American Academy of Allergy, Asthma, and Immunology, which is the Quad AI for asthma.org, or the American College of Allergy, Asthma, and Immunology. You can search for allergists in your geographic area. Then when you go to their website, you can look at what their specialties are. And if someone says they have a specialty in EOE, then that's the person to see. But the treatment plan should be something that is effective and something that you're comfortable with. So that's the sitting down and having, this decision. It is, I just talked to a patient of mine who, I've been seeing him since he's 5. He's probably 35. I haven't seen him in a few years. I just called him because I sort of winding down my practice, and I called him. He said, "Dr. Holbreich, yeah, you remember 5 or 6 years ago, you told me that I should see a gastroenterologist because I was having trouble swallowing?" I said, yeah. He said, "I just blew you off, but it got really bad, so I saw one." I said, "What'd they say?" He said, "I don't know. I got some letter in the mail." So he sent me the letter. I mean, the doctor just said, "You don't have cancer." It was a letter, a form letter. "You don't have cancer. You have white blood cells in your esophagus. Start an acid blocker, 40 milligrams twice a day. I called a prescription to your pharmacy, and you'll come back in 3 to 6 months for another endoscopy and another dilation." So he had he said, "I took an acid blocker for my primary care doctor. It didn't help me." He said, "There was no conversation about what to do." I said, "It's not good, not good." So you need to find a provider who understands EOE and is willing to spend the time with you.
There's a number of different specialists that can help. And like you said, APFA does have a specialist finder. I put it in the chat for those of you joining us live. For those of you watching the recording later, you can go to apfed.org/specialist. And it's a great database of people that have self-identified as having an interest in treating eosinophilic disorders. It includes allergists, gastroenterologists, feeding specialists, registered dietitians, a whole wealth of different types of clinicians that can help people with eosinophilic conditions. And depending on the challenges that you or your child are undergoing, there's a variety of different people that can help.
I'd like to make one quick comment, and
Sure.
I think having, EOE is food driven. How it's food driven, we don't know. These diets that are recommended are called empiric diets, whether it's one food, two foods, three foods. They're just sort of a good guess. There's no test to do it. And I think when people become frustrated because the diet's not helping, the diet's difficult, or, they may seek an alternative provider, a naturopath or a nurse practitioner who specializes in food sensitivities. And they have thousands of dollars of tests done, which are typically not covered by insurance. They get put on crazy diets that don't help them at all, and they spend a lot of time and money. So you need someone who's expert in EOE, and that, in my mind, is an allergist or gastroenterologist to make the diagnosis and come up with a treatment plan. If that treatment is diet, then a dietitian, there are not that many of them, but there's some on the APFED website. There's a group of dietitians called Indana, which are dietitians specializing in food allergies. I participated in a paper we published a few years ago about how to manage diet, and they can be very helpful, but not that many dietitians are expert in EOE or food allergy. So diet is a tough road to hoe.
Yes. We also have some questions and comments coming in about medication concerns, specifically about side effects, even about the taste of the different medicines. So one person's talking about how the taste of swallowed steroids is awful. Another person is asking about acne being developed from steroids. Another person is concerned about using them because of the potential for side effects. Can you talk a little bit about side effects from steroid medications?
Okay, so steroids come in many forms. They come in injection forms. They come in tablets called prednisone. If you've ever had a knee injection it's probably some sort of cortisone. They come as inhalers for asthma, and they can be made into liquids. So if you take steroids that are absorbed into your system, such as an oral tablet of prednisone, within 4 to 6 months of daily use, if not sooner, you'll begin to have a whole series of side effects, which are problematic and troubling, including blood sugar problems, cataracts, bone loss, muscle loss, depression, just terrible. And if you see anyone who's had a organ transplant or has severe disease and they are on oral steroids, meaning swallowing a tablet, they're going to have terrible consequences. If you use a steroid that you swallow in the form of an asthma inhaler, you're talking about micrograms versus milligrams, so 1,000 times less potency or less potency. And there's something called first pass metabolism. When the steroids are swallowed into your esophagus, they go directly to your liver and out of your body. So we know that the only complication of swallowed steroids is candida, which is a topical yeast infection. It's not that common, and it can be usually addressed with either treatment or often does not need to be treated because it's not symptomatic. So using swallowed steroids in the doses that we recommend for eosinophilic esophagitis, many studies have shown none of the side effects that you'd expect with swallowing prednisone. So there's no diabetes, no adrenal suppression, no depression, no anything. So they're safe for long-term use, and I've had many patients on them for years and years and years and years. Now, in terms of finding a product that is adequate for you, you know that nothing is approved by the FDA, and that's been a concern for us because nothing has been approved. In development now, which we hope will be coming out in not too long a period of time, is something called oral dispersible tablet. They're available in Europe and have been very, very successful. And this is a tablet that you would put on your tongue or under your tongue, and it dissolves. and coats your esophagus, and it's a single dose at bedtime. Now, for those of you who are using swallowed steroids and who don't like the way it's going, there are a couple of suggestions. One is to use a steroid powder. Now, if you go to YouTube and type in my name, Mark Holbreich, you'll see a way of using something called Flovent powder, which is tasteless, odorless, and is extremely effective in treating eosinophilic esophagitis. And it's demonstrated on there how to use it. We use it slightly differently, just twice a day. So that's one option. I don't like using asthma inhalers, particularly because swallowing a spray is sort of counterintuitive and can be problematic. Then there are swallowed steroids that are budesonide, which is a liquid, or a powder, which is mixed with something like agave, honey sweetener. Now, compounding pharmacies make this up, and the cost is variable, anywhere from maybe $40 a month to $100 or $200 a month. And you can search in your area for a compounding pharmacy that makes budesonide suspension. It usually comes as 1 or 2 milligrams and is used once or twice a day. Now, those can be flavored. So if the pharmacist is making it up and you said, I don't like the taste of this budesonide, then they can change the flavor. Now, if you're using it at home by opening up a budesonide vial, because it comes as a liquid that's used for children and nebulizers, some doctors recommend you buy the vials, you open them up, and you put them in Splenda. So it's usually 5 packets of Splenda and 1 ampule of budesonide. A lot of people don't like the Splenda. They just can't tolerate it. So there are options. Honey is one. Applesauce is another. All you need to use is a small volume of applesauce. Some people use agave, and that modifies the taste. So there's always a way to deliver the swallowed steroids in a way that's palatable and safe. Now, one of the tricks, for those of you who are taking swallowed steroids, which I think is important, is that one, there's no eating or drinking for 30 minutes. That's absolute. That's not, you can't swish and swallow or brush your teeth. You just can't eat or drink for 30 minutes. And the second thing is that when you take the nighttime dose, taking it at bedtime is much more effective than after dinner, because when you sleep at night, you swallow less frequently. So if the idea is that you're going to swallow this and it's going to sort of stay in your esophagus for a few hours, then if you're swallowing frequently in the evening while you're watching TV, you swallow frequently, it's going to sort of wash that out. Now, that's sort of what we think. But a nighttime dose is preferable, a bedtime dose. So I tell people, brush your teeth, get ready for bed, take your swallowed steroid or your fluticasone. And for those of you struggling, and I think Dupixent has been great for a lot of patients because they failed other things, but they sometimes fail other things because they're too much of a pain. And I think the Flovent discus, which is on that YouTube video, for those of you struggling with swallowed steroids who are not ready for Dupixent, that's been very effective. And many allergists, gastroenterologists wouldn't know about it, but allergists can figure it out. It's a little tricky because you have to take the device apart, you have to get the powder out, but it is really very simple.
So in addition to steroids, people have questions about PPIs, about the long-term impact of them, about the waxing and waning of, do you just take them long-term or do you take them for certain periods of time? So those are some more
Yeah,
challenges of adherence. What
right.
can you talk about
So
PPIs?
PPIs, PPIs have been used more frequently in children who the parents feel have acid reflux, or the provider feels to have acid reflux. There's been some new data suggesting that PPI use in infants contributes to food allergies. So there is some risk if you have a child with atopic dermatitis at an early age, or at risk for maybe food allergies. Then it's a conversation. Does this child really need an acid blocker for their acid reflux? Is it a question of so GERD is gastroesophageal reflux disease, and then they're spitting up. Okay, is it spitting up or is it disease? Disease may need medicine. Spitting up needs more loads of wash. So PPIs in young children, we're a little leery of. In terms of using them for treating EOE, I think they can be effective in patients with mild EOE. So if you've had mild symptoms and you don't want to use a swallowed steroid, a PPI can be effective. The studies show that PPIs are effective approximately 40% of the time. So that's why the recommendations are if you start a PPI and that in 6 months you get a scope to make sure it's effective. My experience with PPIs is that many people have been on them because they've had them taking them for symptoms. Now let's talk about adults. They've been taking PPIs for other reasons and it never helped their dysphagia or their difficulty swallowing. And my personal experience is that they're failures. Now, I do not think, and I've talked to gastroenterologists about, there are any side effects from long-term use of PPIs, but they have to be used chronically. You can't take a PPI when you start having trouble swallowing. And so there are these population studies which shows maybe that there's Alzheimer's, but more in people who take PPIs or not. But those are these huge population studies which look for factors, and there's never been anything consistent. So a PPI works well for you, then there's no problem staying on it long term. My personal bias is just my bias is that now I know many gastroenterologist colleagues who say the GIs are very comfortable with PPIs and not so comfortable with steroids. They never use them. Allergists will use it for the skin, for eyes, for nose, for asthma, for everything. We're very comfortable with it. So if someone has been struggling for a long time and I want to make them better quickly and I don't want them to have a dilation, I'll start them on swallowed steroids. So, and the swallowed steroids, as I said, are very safe. So PPIs are a mixed bag. Now, there's the occasional patient who says to me, I use my swallowed steroids for a month or 2 or 3, and then I feel better, and then I stop taking them. And maybe 2 or 3, 4 months later, I start noticing I'm choking again. I get back on them, and I take them again. I think the problem with that is sometimes these patients will go off. They're having a little problems. They kind of delay, and then wind up having an impaction. Impactions can really come up and bite you when you're not expecting them. So PPIs are not my favorite, but in some patients they work well. I'm a fan of swallowed steroids if they're used correctly and in the proper form.
This brings up the question about the third kind of category that's come up more recently in frequent years. And so we've got a question here of what are the points when someone should consider when deciding between Dupixent versus a steroid, such as budesonide or Flovent?
Okay, so the first answer is simple. If you are now there's the company that makes Dupixent has applied for, it's now approved for 12 and over. They've now applied for it for 1 to 11. So it is a safe product. If you have a child who has asthma, atopic dermatitis, food allergies, who is scratching a lot of, there's no question that Dupixent is a great medication for them because it treats multiple allergic problems, including atopic dermatitis, asthma. My experience has been that children and young adults don't have a lot of asthma and atopic dermatitis. So then the decision comes, should we use Dupixent? Now, currently, I think it's sort of definitely a shared decision-making discussion. If you're on a swallowed steroid and tolerating it well and are having good control of your disease, whether it's a child or an adult, and you're happy with it, I see no need to go to Dupixent. Now, Dupixent is a weekly injection, and it's about $80,000 a year. Now, with patient assistance programs, you'll pay very little or none. But like I say, someone's paying $80,000. So it's your insurance company or whoever. So it's a very costly medication. And at this point, I think it needs to be reserved for patients who fail PPIs, who get chronic yeast infections in their throat from swallowed steroids. Well, who fail PPI and steroids, and maybe diet. But the patients who go on Dupixent have done very, very well. I mean, there's no question that Dupixent is a great drug for EOE, and it's the only one approved by the FDA. The side effects of Dupixent are uncommon. So it is a good medication for people who have struggled with EOE for years, particularly if they have other comorbidities, asthma that requires daily inhaled steroids, or atopic dermatitis. It's a great solution. But again, it's something you would need to discuss with your provider. And unfortunately, I'm a solo practitioner, and I've been doing it for many years, and I sort of control the times that I spend with patients. And my staff knows that if it's an EOE patient, they're going to block out an hour because they know that between allergy testing and reviewing the biopsies and the endoscopies and coming up with a plan, it takes a long time. I mean, because it's a life-changing visit for patients. What I like to hear from patients when they come back in 6 weeks or 8 weeks is this has changed my life, because they go from being fearful at every meal to eating comfortably. So, if you're making a decision in the patient for some sort of lifelong care, you need to have that decision making conversation with, what do you want to do? What are you going to be comfortable with? Because whatever you pick, you're going to have to stick with it until it stops working, or if it doesn't work, switch.
So that tees up a question that we're getting from a number of different people around teenagers going off to college students becoming young adults, and multiple parents sharing that they're seeing a challenge when
Hmm.
their child goes off to live on their own,
Right,
and they're not always taking their medications as consistently
right.
as they were when they were under their parents' care. So what advice do you have to help people understand that EOE needs treatment and ongoing monitoring?
Yeah. I think that's just an issue of adolescents and young adults, in terms of not wanting to be tied down to a medication every day. I think, again, it's not a good solution, but sometimes I say to parents, if they're having trouble choking, if they're having problems, they're gonna want to get back on their medication. So if you've been monitoring them and they go off to college and they're fine. Now, the thing is that we recommend these medications for asthma, for EOE, twice a day. You take an inhaled steroid for asthma, 2 puffs twice a day. You take something for EOE morning and evening. What happens if you take it 4 times a week, or 3 times a week, or 5 times a week? Are you going to get control, or some level of control? And I suspect, and when I talk to a lot of patients, and I say, okay, you're supposed to, particularly adolescents, and if they're taking the Flovent discus, which I like, which the powder, I say you're supposed to get it in 14 times a week. How many times are you getting it in, actually? They say, 7, 8, sometimes 6. I say, how do you feel? They say, I'm doing fine. And then they say, if I forget it for a week or two, I can tell. But, 6 times a week, 5. So, it's not 14 times a week. I mean, we think it's 14 times a week, but there have not been studies that look at 7 times a week or every other day. So I think it's a combination of saying to your adolescent, listen, the doctor wants you to take this medicine every day or twice a day. Do your best. I know it's not going to be perfect. Look, we look at adherence in adults in that Dutch study, 60% are not adherent of adults. So you can think, and in that study, actually, the younger the patient, the more likely they were to be non-adherent. So you take a 20-year-old versus a 50-year-old, the 20-year-old's going to be more likely to miss their meds. So if you say, listen, if you're having trouble, difficulty swallowing, you just need to be more conscientious. This doesn't turn into cancer. This doesn't, people don't wind up in their 60s, having a feeding tube in their stomach because they didn't take care of their EOE. This is something that the worst outcome is you get food stuck in your esophagus and you have to go to the emergency room, which is not pleasant, and it's expensive and it's scary. And you don't want to call from your child saying, I was out with my friends and I had a hot dog and now I'm in the emergency room and it's stuck in my throat. And, I can't swallow. I can't drink water. I'm, uncomfortable. It's okay. Take your medicine next time. But so the concern of children go off to college is the same thing. I mean, all these kids I take care of food allergies, they all go off to college. The parents are worried. The kids do great. I mean, they do great. Same with the asthma kids. They may not take their medicines every day, but they get along. So I would say, listen, you say, do your best to get your medications on some sort of schedule. If you can only take it once a day before you go to bed because you're busy in the morning, just try to get it in, once a day. And and see how they do. And I think that what you don't want, which I think happens, is they start accommodating. They start saying, I'm not going to have that steak for dinner. I'm going to have, pasta. I'm not going to, I'm not going to, I'm going to take my time eating. I'm going to drink a lot of water and help it get down. And in the questionnaire that we sent out, when we talked about how they manage, we had a question about how well do you manage it. A lot of patients say, I get by. Now, what does I get by mean? So I get by meaning I eat like my brother who has no EOE, or does it mean that, yeah, I chew a lot, I drink water, I watch what I eat, I get by. I don't need medicines, but I get by. And I think that many, many patients with EOE get by, and they don't want to go to the doctor. They don't want to take steroids because, their aunt had steroids and she got a fracture, and, because she was taking prednisone for rheumatoid arthritis or something, they say, it has too many. When you use the word steroids, people don't distinguish from a tiny dose that you inhale versus a pill that you swallow that is really problematic. So, yeah, I think people don't even bother. I don't want to get scopes. I want to go to the doctor because he's going to make me get a scope, or she's going to make me get a scope. They prescribe this Flovent inhaler for me, and it's $250 a month, and it's not covered by my insurance, or I have a big deductible. I can't afford that. So I've worked with patients, to find something that is, sometimes I'll say to them, okay, I want you to use this product for go to the pharmacy now and ask them how much it's going to cost. And if it's any more than 200 a month, we can get it for 50 a month, or 40, 50. We can have a compounding pharmacy and do it. So you have to be innovative. You have to look for ways that make the patients happy. And for college students, listen, I think I'd be more concerned about a child who has peanut and milk and egg allergy getting, milk by mistake at the cafeteria than I would a child with EOE not taking their medications regularly because, worst comes to worst, they'll just adapt their eating and they'll deal with it. It's not dangerous.
Well, thank you so much for all of the information and insights that you shared today about EOE and treatment adherence. We also want to take a moment to make sure we're thanking our education partners for their support of this webinar series, including Bristol Myers Squibb, GSK, Sanofi, and Regeneron. As we look ahead to future opportunities and other ways to continue learning about eosinophilic esophagitis, we encourage you to check out APFED's podcast series. One of our recent episodes, we talked with Dr. Stephen Ackerman and Robin Shandis about esophageal string test. You can find the episode at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more. Another great way to continue learning about eosinophilic disorders is our annual patient education conference, EOS Connection. This year's conference was held in Denver in July. The good news is we recorded every single session, and the presentations are available to watch on demand at apfed.org/conference. In fact, APFED members can register for virtual access for free. We also encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. Go check it out at apfed.org/connections. So thank you again, Dr. Holbreich, for joining us today for APFED's EOS Support webinar series. If anyone has a question that didn't get answered today, please email mail@apfed.org.
And can I say one last thing?
Sure.
We are in the process of designing a study to look at and answer all these questions. So my email address is up there for those of you who would want to share with me some of your concerns about adherence. They're very, very good questions today. I think they're questions that every patient with eosinophilic esophagitis deals with. And I think that we are fooling ourselves a little bit as providers to think that people listen to us, because they probably don't, and they probably get by, and they probably struggle a little bit, but they don't, and we need to understand, what's our job in terms of providing information and the right care, and find out patients what patients are really doing. So as we design, questionnaires going forward, these questions about your concerns are very helpful for us. So feel free to email me to list your concerns.
Well, thank you so much and good luck with that research. We look forward to learning about the findings. So, alrighty. Well,
Appreciate
everyone,
your
thank you
time.
for joining us today. Please have a great afternoon. Bye-bye.